which is part of that patella and quadricep group, right? And then there's the tibial tuberosity. So there's nice big tibial tubercles here from Lodgewood's, right? So you can see that one quite easily. You won't be able to see it so easily on everybody. Then there's two more palpations moving laterally. So you guys were looking for the Gerdy's tubercle, and again, it's really prominent on this athlete. You can actually see it without palpating, and it's not so on many athletes. So it's basically the bottom of that ledge on the tibia, and then I can go one more over, and I should be able to palpate the fibular head. So I think Alice was saying she could remember it by being a triangle, if that's what you kind of need. Some people will have it more parallel, but it goes 1, 2, 3, and I can feel the fibular head. So I know that's lateral, and I should be able to palpate the whole length of the fibula, and I know that the lateral malleolus is part of the bottom of that fibula, right? So we've got tibial tuberosity, Gerdy's tubercle, so patellar tendon, Gerdy's is iliotibial band, fibular head is part of the lateral collateral ligament. So I could be able to palpate, I should be able to palpate at least the femur, so the condyles of the femur. And if you look at Carl here, I've got like big knobby condyles. I've got the lateral on this side, medial, and then the epicondyle is the bony bump that sticks up from the condyle that receives that ligament attachment. So that would be the lateral epicondyle. And you know, for some people, it may not be as prominent, and sometimes they call the tibia having a lateral and a medial condyle as well. So be very specific. We were talking about that. You must be specific if you're talking about the femur or the tibia. You're going to palpate the patella, and you're going to palpate the joint line. We've done all of those. Remember, the popliteal space is the soft space in behind the knee. That's where the swelling likes to go. So that's good to palpate for swelling. Also knowing that those all tendons come in together there. And then I think that's it. You guys were able to find the others. You should know the muscle attachments and know the IT band is on to Gerdy. So you can actually, if you just lie on your side for a sec. I know it's very comfortable where you are, but if I know where Gerdy's is, and I should be able to palpate that tight IT band here. So know where that palpation is. So it's pretty tight, and I know that if I keep palpating up the IT band, I can feel how tight that is, and that needs a good rollout for sure, right? And then it goes all the way to there. So get your hands in and see what that soft tissue feels like. All right, back on your bottom again. So in terms of the functional testing, the first two on the list, did we do overs and squeeze? You've done that, right? I think we did that last time if you were here. We'll start with valgus and varus stress testing. So if I think it's a medial collateral ligament, I'm going to extend the knee, and I'm going to simply apply valgus force to it. And I'm trying to stretch that out. And I can do it the opposite way. Just tuck the foot underneath your arm, and it's bigger. It's harder on bigger structures, but just kind of support that way. And then I'm pushing into varus. Now the other thing you can do is you can slightly, I'll do it this side so you can see. I'll slightly flex it, so I can extend it. But if I slightly flex it, it might take the stress of the muscle off it a little bit that's contracting it, and then I can test it again. So I simply put it into valgus and into varus. In terms of, so you can see here, valgus and varus stress testing, it isolates, right? The problem that when it's straight is other ligaments and other muscle tendons will stabilize it, so you can flex it to isolate the collateral side. Okay, in terms of ACL, the first one I'm going to do is called the drawer test, very similar to what you did in the ankle, but I'm going to flex the knee. So the athlete could be slightly sitting up. They don't necessarily have to be completely laying down. If you get them to slightly flex their hip, again, that helps to relax it so that you're not contracted, or that the hip flexors aren't contracted, and that's keeping the knee up. So on the anterior drawer, you're simply putting your fingers behind the knee so you can feel the tendons of the hamstring, because then you'll know if the hamstrings are contracting and keeping it tight, because then you can't slide it. If they're contracted, then they're going to keep it from sliding forward, so relax. And then I'm going to put my thumbs basically on the joint line to see if I can feel any shifting or movement forward, and then I'm going to give it a nice pull. I'm going to open that drawer. There, get your foot up right there. And I'm going to just pull it forward. And it's really important to put your fingers back there just to know if there's any spasm or something that's holding it out of place. Now, there's lots of reasons why the ACL is not ideal, and part of it is because of other structures contracting to keep it solid. So you might have an ACL injury that gets masked with this position. So what they often recommend is to modify it. And the modification is just keep it straight. And so what I do in this case is I put my hand underneath, and I press down on this hand, and I just pull it up towards me. So I'm just opening it up towards me. And the alternate to that, which may be more comfortable for the athlete, flip onto your belly, is to just do it the opposite way. So you're still shifting it, but you're pushing this way. So you're bringing it, there we go. It is, I'm pressing down here, and I'm still pulling it out, right? It's just opposite. But it's just, it's another way of doing a Lockman's. It's a modified Lockman's. Okay, flip over. Okay, so what's next? Lockman's anterior drawer, you should be able to do that. Posterior drawer is just the opposite. And you can often do the anterior drawer and then the posterior drawer. So I open the drawer and then I close the drawer. And if I close the drawer, I'll know if that PCL is keeping me from sliding backwards. Another way to test for the PCL is to just do what's called a posterior sag. So the athlete simply lets their leg go like that. And I start in sort of a gentle flexed position. I hold their toes up like this and then I let go. Well, presumably, if the whole idea of what the PCL is to do is to prevent you from sliding backwards, you're going to see a sag right there if there's no PCL intact. So they call that posterior sag. And I start in a slight flex, and then let them come down to that, and then let it go. And then you can see that sag. So for PCL, we do posterior sag, and we do closed drawer or posterior drawer. Patellar apprehension is good for looking at dislocation. And what you want to do, you can put both legs straight if that's okay, is if they're super relaxed, you might have to put a hand under here to make sure that they are relaxed, is you're just simply moving the patella. So you can move it medially, and then you can move it relaxed. Does that hurt? No. As I'm going to push you, I'm using my fingers just to drive it laterally, because it's more common to have it laterally, right? And if it's a dislocating patella, that'd be really easy. There's lots of movement in there. Oh, come on, your knees hurt? Talking about knee injuries, everybody's knees are hurting, right? So you can see how much movement. And if they're not relaxed, you're not going to be able to get it to slide. So just relax your weight. Give me your weight. Don't give me your weight.
Drop.
You're on a beach in Maui.
Drop it.
There we go. Okay, so you can see how much play you have in there. And that's why I want you to palpate all the way around it so that you can move that patella around and see how much movement you have. So if you have an athlete that has a dislocating patella, that would be so painful. They'll be like, no, I'm apprehensive and I don't want you to do that to me. And that's the sign that it's positive. So that's called patellar apprehension. And I'd like you to test both medial and lateral directions, knowing that lateral is the most common. Okay, next one. Oh, Apley's compression and distraction. So flip over. Sorry, should have brought the pen down. For Apley's distraction, so just put one down and leave one up. Because what I'm trying to do is I'm trying to grind it up to see if it's cartilage, and then I'm going to distract it to see if there's also ACL involvement. So it's a little bit, you have to modify with a big athlete like this. So what I'm going to do is I'm going to put my hand down here, and I'm going to, first of all, do compression. So what I do is I grab the bottom of the foot, if it's a pretty long lever, but I can almost reach it, and then I'm going to just grind it up. So I might just twist it from side to side to try and grind it a little bit. And that should hurt them, if there's any cartilage in there. And so what you're trying to do is hurt them, but not cause so much pain if they're already in pain, right? You just want to isolate the injury. Now when I put my hand here and I pull up, this is distraction. So what's happening is I'm pulling it away. You can see the movement through there. That's a distraction, and that means that the ACL is struggling to hang on. So I'm isolating ACL. Thank you. Okay, so we got compression is a grind. So you can just take it and you can kind of grind it in there. It's all you're trying to do is move it around. Yeah, yeah. And also sometimes the ACL holds it. So when you distract it, then the ACL will have trouble. So the next one is distraction, which it takes the ligament, it isolates the ligament with the pressure off of the meniscus. Okay, the next one, so I told you there was a lot for these. I think this is the last one though. Yeah, McMurray test is interesting. The McMurray test will now say, okay, there is possible cartilage damage, but now we can isolate the side that it's on. So what you do on this one is you can go on either side, and what I'm trying to do is I'm going to extend this a little bit. And you want, again, move him from flexion to extension. But while you're doing that, is you want to externally or internally rotate, depending on the side you're testing, and then flex this way or grind this way. You see what I'm doing? So I go external rotation, varus deformity, and then grind it up. Okay? Or else I can do internal rotation, flex, internal rotation, and I could go valgus deformity and grind it up and slightly move this way. Okay, so all you're doing, I don't know if you can see with my arm, it's easier to see on this side, but I'm just rotating, externally rotating, or I'm internally rotating, and I change my body position to do that, and then I'm putting the valgus or the varus force on it to see which side the cartilage is. Okay, so that's called the McMurray test, and that gets you through the full line here. So you should know how to do each test, and you should know how each of those tests to do test for. Remember, there's twice as many in your book. So I've taken the ones that I think you need to know. You don't need to know the other ones,